And I'm not going to introduce these two guys, but Colin is going to introduce these two guys. Colin Hennessy is now a principal consultant for pharmacy healthcare initiatives. And his credentials are he graduated from the University of Michigan with a bachelor's degree, a master's in public administration, and a Pharm B degree, and completed a clinical pharmacy residency at the University of Michigan in the University of Michigan Hospital. So it's really wonderful that Colin also has some really good insights, I think, and opinions about the topic that we are going to be covering today, which is really around the question of quality versus quantity at the end of our lives. And we are really going to be talking about medical and ethical issues. And please, we have begun to have a conversation already. It's going to be a great conversation.
Okay. So the way our game plan is we're going to have Mark and Ryan are going to give brief little presentations and really open it up to get questions and feedback from all of you. So hopefully have your questions ready and let's see how that goes. First, I'd like to introduce Ryan Ferdihert. Did I get that right? Ferdihert. Who is chief of the ethics department for multi-care. Comes to us from Pittsburgh. He's an adjunct faculty at University of Puget Sound, lecturer at University of Washington, and has daily patient care responsibilities on the floor at the hospital to help with ethics questions and chairs an ethics panel at the hospital. Next to Ryan is Mark Fredersen, who is a practicing naturopathic physician, graduated from Bastyr University, 22 years experience as a physician. Prior to that, he was an ordained Methodist minister, and he's going to provide us some patient care situations that he's had as a practicing physician. So, start on.
So I just wanted to speak first for just a little bit to give a little background. I'm very informal. If anyone has any questions, I know some of the things I'm going to talk about are a little strange. I might be throwing out some words that you haven't heard before or never heard actually applied in this manner. So please raise your hand or just yell out. That doesn't bother me. So first off, I'm just going to throw it out. Can anyone give me a definition of what is ethics?
Foundational principles by which we live and make decisions.
Very good. That's like the best definition I've ever heard. I've been struggling to come up with a better definition, but I'm just going to steal that.
Repeat that, please. What did you say again?
Foundational principles by which we live and make decisions.
Very good. So I distinguish, you said moral foundations. There are, in my opinion, there's a difference between morality and ethics. Morality is, to some extent, the way we personally feel about things, how we make these decisions and what we determine is right and wrong. Ethics is more of a system of rules, standards and protocols that determine what is right and wrong. So one of the easiest questions, or one of the best answers I can give for what is ethics I studied philosophy, that's my background. Ethics is not necessarily the determination of what is right and wrong, it's more of the study of right and wrong. So why is what we say good, good? Why is what we say bad, bad? Some will argue that it's a division of aesthetics, so the study of what is art, what is beauty, and think of it as the same way as you look at a painting and you can say that's a good painting. Someone else may have another opinion and say that's not a good painting. It's very subjective. Art is very subjective. So how do we determine what is good and bad within art? We can apply that to moral behavior. What is good and bad with our own actions? So for a couple thousand years, we've been trying to figure out what makes a good action. Is a good action good because it's good within itself, or is a good action good because we as people have determined it to be a good action? It's kind of like a chicken or the egg situation. So I work in a field, it's called bioethics, medical ethics, clinical ethics. It's smaller fields within that. What we do is we've determined it's a field called principalism. And in principalism, we have created what is called the 4 principles. And those are autonomy, beneficence, non-maleficence, and justice. And we work to balance all 4 of those ethical principles in every time we interact with a patient. If all 4 of those could be upheld, Perfect. That is the greatest situation ever. A good situation, patient is complaining of painful urination. They come into the hospital, doctor says you have a UTI, prescribes an antibiotic. Patient takes that antibiotic, their insurance pays for that antibiotic, they take it, they become good. Autonomy, the right to self-determination, you have your own right to health care. We cannot force certain procedures on you. If there's a surgery that you need, we will ask you do you want to do that surgery? We can't just do it without your permission. Beneficence is our obligation to do good. We have to do what is right for the patient. We have to do the good for the community and the group. Non-maleficence is not doing harm. It sounds kind of the same as beneficence, but there's actually a lot of divide of when is doing good also not doing harm. And then social justice is the idea of equal distribution of resources. We are not allowed to restrict care based off non-important factors. So if a man comes in complaining of lower abdominal pain, he may receive certain tests. If a woman comes in claiming the same pain because different genders, different sexes, you will receive different tests. But if two women of the same age come in, they should receive the same treatments no matter what. When two of these principles or two or more of these principles come into play is when we have what is essentially an ethical issue. If you have a procedure and the physicians believe that this is what is in your best interest, but you do not think it's in your best interest, that is whenever we have an ethical issue. So do we do what is best for the patient, or do we allow that patient to make the decision themselves? Are we violating our obligation of not doing harm by allowing a patient to make a decision that we think is not in their best medical interest?
Who makes that decision?
And that's the question.
Oh, but does that come to a committee or something at your hospital?
Yes. Or it'll come, we have ethical consult services. So if a physician or a family member, anyone in the hospital is allowed to request this, and we'll come in, and we'll do an assessment, we'll have interviews, questions, work with the team, work with the family, and then try to come to a consensus.
What
Yes.
percent are you dealing with people who you already know have what everybody's wanting to get out of this weekend, getting to advanced care directives?
Could you repeat?
So if are you in conflict when there's advanced care directives, if it's not with your medical reasoning?
We use them almost extensively. If there is an advanced directive, we will follow that and make that one of our highest priorities. If there are extreme circumstances, we can work with the families with them and reach an understanding, but mostly if a patient has an advanced directive, there's not really an ethical issue because then we understand what they would want. Yes?
I think where it gets difficult is with children, with people with Alzheimer's or dementia, brain issues, and with religion.
Yes. There's some debate right now in the ethics community of patients with diagnoses of dementia. When do patients with dementia lose their decision-making capacity? Is it immediately upon diagnosis, or is it a gray sliding scale? And if it's a gray sliding scale, what is the trigger to stop it? When do we reach that point? A lot of times for decision-making capacity, we will do a technique called teach back, where we'll explain the medical procedures, explain the information, and then we'll ask the patient to repeat it back to us. And if they seem to have a strong enough grasp of this, then we'll move forward. But I also argue that no patient has ever given true informed consent or truly understood the autonomy, because you cannot know everything that's going to happen. For you to textbook give informed consent, you have to know all the consequences of that action, everything leading up to that action, and then fully aware of everything that's going to come from that action. You're not allowed to be influenced by any outside factors, including family or stress. If you can tell me a patient in the hospital who is capable of not being influenced by family or stress and understands everything that's going to come from their decision, then you have a patient who truly gave informed consent. I don't believe that has ever happened. So one of the major, coming to why we're here, one of the major ethical issues is end of life, discontinuation of life support. We have patients who sign advanced directives, and then the family are saying this is not what they would actually want. I don't care what that piece of paper said. They would want full aggressive care, not comfort measures. What do? Do we follow the family, or do we follow the will of the patient? How expressed can the advanced directive be expressing that will of the patient? Is it just, I don't want life support? Or is it I want a time trial, or I want to try life support for some time? We have some patients who will go on the ventilator for 2 weeks, and if I am not recovered or you don't see any clinical improvement, then we can talk about removing it and seeing if I compassionately, we call it compassionate withdrawal, if I pass away because of that. But having these kind of conversations are very challenging. As you mentioned with honoring choices, people don't want to have these kind of conversations whenever they're healthy. They really don't want to have these kind of conversations where it really is life and death and it's on the line. So one of the major things that we do when we do an ethical consult is we try to understand the goals of the patient, the intent of the patient, and what is quality of life. And when does quantity of life override the ideas of quality of life? Would you rather 10 years on a ventilator, or would you rather 7 years doing what you want to do?
Isn't that what the end of life documents are about, so that those decisions are already made? Or am I missing something here?
One of the problems we have with those documents is they are not always updated. So we recommend that you update your advanced directives we call it the 5 Ds. It's every decade, every diagnosis, every decline, divorce. If you go through a divorce, Honoring Choices is the program. We believe it's an ongoing conversation. It's not necessarily about getting advanced directives completed. We believe in what is called advanced care planning. So it's ongoing conversations intended to get at the goals of the patient. So even if you don't have a documented advanced directive, but you've expressed to everybody that if this situation were to happen, this is what I have determined to be a quality of life. I go hiking every weekend. If I am not able to do that, then that is not quality of life for me. And if you come into the hospital and everyone is aware of that, even if you don't have an advanced directive, we can work with the ethics team and say, this is what we determine is not quality of life for this patient, and that by continuing them on life support, possibly against their will, we are violating autonomy and we're violating non-maleficence. We are doing more harm by treating than we are at letting this patient have the death that they actually want. Yes, 5 wishes is a strong advanced directive. There's some wiggle room in the world of advanced directives. Some advanced directives are what are essentially court-approved advanced directives, and some are just expressions of wishes. So if a patient has a letter, that could be considered to some extent an advanced directive, as it's outlining goals of care, but we can't go in front of a court and say, the family's saying this, but we're going with what the patient actually wanted outlined in an advanced directive. If you have a letter, that's a little more gray. If you have a completed 5 wishes, a completed PULSE form, a completed, although PULSE is not an advanced directive, I don't want to go down that. Honoring Choices advanced directive, the new one that's out, and also the Washington State advanced directive, we can put those in front of a judge, say, this is what the patient said that they would want, and the family is disagreeing with us, but this is what the patient want, and the judge would agree with us.
So the answer is yes.
Yes, that is a good one. 5 wishes is good.
You're saying like a notarized letter doesn't stand up in court?
It would stand up if there's other supporting evidence, but in terms of...
The notarized letter itself,
would not be good
what's
enough.
the point of getting something notarized?
Well, now you have to get your DPOA paperwork notarized. Since January, designated power of attorney, that's the person who makes healthcare decisions for you. Washington changed the law in January. Now it has to either be witnessed by 2 people. Those 2 people are not allowed to be family members or healthcare professionals, which doesn't make sense if you eliminate those 2 groups, or it has to be notarized.
And that's different from the medical power of attorney?
That is the medical power, little technicality. The DPOA is the paperwork, that's what it's called. The medical power of attorney is determined by the DPOA paperwork. So a DPOA determines who the medical power of attorney is.
When do they take over?
They take over whenever the patient is determined to not have decision-making capacity.
And who determines that?
The physician usually. But that is also a very subjective.
But
And
sometimes it could be included in the...
It could be, yes. But there are some ethical consults.
Sometimes that language could be included in a deal.
There are some ethical consults that we have done where the patient is, we're not sure if they have decision-making capacity, and they're saying something that goes either against their advanced directive and their family. So do you follow what the patient's saying right now, or do you follow what they said 6 months ago in the paperwork and their family is in agreement with.
So if my partner and I both have GPOAs, are you saying that they would not be retroactive?
They are grandfathered in. So it's all new DPOA paperwork has to be notarized, but if you have previously completed it and it is on file, then those will be carried over.
I think
Maybe we,
I'm trying to.
maybe a couple things. Maybe we could touch on, get back to this, but I was going to, give Mark
Yes.
a chance to maybe before we get going.
Well, it's difficult to know how to plug in exactly to the to the. I think that I come at the questions largely from a pastoral and engaged physician sort of position. As a naturopath, I have tended to do a whole lot of what I call medical companioning, where I actually will, I have a number of different people from the same family who all see me, and so I know the whole family, and so I've walked with a couple of different families who have gone through experiences of cancer and intensive care units and being on respirators and that sort of thing within the family unit. So I have kind of more of a, I don't want to dish the more organized academic approach to it, but I've kind of lived it out with a number of different people, and so I bring that sort of more whole life sort of perspective on it, and I've tried to make it a little more academic. So one of the things that I thought about was when somebody is dying, let's call the person of interest here who's got a terminal illness and is going to be dying, and we'll call that person A. That person comes to that experience with a whole lot of values that they see about their life. And those include things like honor, respect, dignity. And if you talk to people, they're very concerned about how they're going to lose dignity, how they're not going to be respected, how they don't know how they're going to hold on to their honor. And they get very worried when they start looking at those end moments where they're going to have to go into a hospice situation or something like that. So, and as well as some others that you might be able to think of. On top of this, though, there is also these other layers that come into play that include things like cultural values, social norms and expectations, such as a family's understanding of what should happen for A. People who aren't ready for A to go yet. There's the financial parts, of course. For us, for A, he's worried about what's going to happen to his family after he goes away. There are religious concerns, and all of those play into these to the values that person has. So when this person comes in to a critical care situation where they're at the end and we've got to decide, are they going to go into hospice, or are family members going to stay at home and take care of them, which I've had happen in one case, or are we going to submit ourselves to the hospital institutional sort of medical system? A has some ideas and feelings about that, but also so does his spouse, who is B, his children. And for each one of those letters, there's this system going on as well. And then you take it into the medical field, and each of the people who walk into that room with that patient have all of that going on with them too. So suddenly the decision-making process, we've boiled it down as best we can in an academic kind of way that really helps the hospital folks decide what can be done and what can't be. It doesn't really deal adequately with the mess that's all of this. right? And that's where all of the emotion, that emotion is another one of those circles out here, that there's emotional norms and expectations too. So let me share a fairly long story of a man who died 7 years ago today, in fact. So it's kind of interesting that I'm here at this moment, because I walked with him and his family through this process that he was diagnosed with rectal cancer, and stage 4, metastasized to his liver. Did not look really good, but we did a combination of chemotherapy along with naturopathic medicine. And he was doing fabulously well, so well after several months of chemo that they decided that it was time for surgery and to resect the tumors from the liver and take care of the rectal tumors. So they went in, the first abdominal surgery, and the word first there should say that things are not going to go well here. The first surgery went really well, and they got everything they needed, but about 36 or 48 hours later, he started running a fever, his blood counts were coming down, and they figured, well, we better go back in and see what's going on. They went back in, spent 3 hours, weren't real sure about what was going on after they were done with it, and sent him back out. He ended up going home with a wound vac because they had not closed him up well enough. So he went home with an ostomy and a wound vac. About a couple weeks later, he starts running a fever, and I was pretty concerned that we were dealing with some sort of an infection, but wasn't really sure. But I said, let's go back in and see about it, because the wound isn't really healing up, and I don't know what's going on with this fever. So we went in and saw the GI doctor, and the GI doctor said, wow, that wound is really nasty. I don't know what to, basically said, I think that everything's fine, don't worry about it. So we went home and continued for another couple of days, and the man started having some seizures. His fever stayed where it was at. Didn't quite know what was going on and tried to manage it at home. I went ahead and prescribed the antibiotics for him because I thought something was going on. And the seizures became more frequent, and we finally said, we got to go into the ER. Well, we went into the ER, and as soon as we were there, they said he's septic, and immediately he was taken to ICU and put on IVs. And later, that was about 2 o'clock in the afternoon. By 8 o'clock, he was starting to have real difficulty breathing. Now, he had told his wife, and she had the medical power of attorney, so he had told her that he did not want to be on a respirator and life support and everything. He just wanted to go when it came time for him to go. So he started having trouble breathing about 8 o'clock, and they put, basically there was a stair-step process that happened here. That first of all, they added some oxygen, and then they added a mask, and at each step along the way, the medical folks were saying, well, we've got to give him the antibiotic a chance to work. We've got to see if this is going to work. And so his wife kept saying, okay, 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 and ended up till we were down to the point of, okay, it's time for a ventilator by midnight that night. And the wife did not really want to put him on the ventilator, but the staff at the hospital were putting heavy pressure on because he was only 47 years old. It's important that you give your kids a chance to say goodbye, and you should go ahead and do this. So finally, the wife and I ended up in a real fight over it, but ended up with her going ahead and saying, okay, put him on the ventilator. He was in ICU on a ventilator for 3 more weeks. And the thing that turned the decision was that he had a major seizure and they took him in for an MRI, and he had a brain tumor. And his wife said he would never want to live that way with a brain tumor or anything going along with it, even if we get him off the ventilator. So she had them pull the ventilator, and was told that he'll die within 8 or 10 hours. Well, 3 days later he passed away. So that's a story that. There were a lot of different ethical sort of tough decision-making points along the way. Some of them were, obviously there were all the medical ones, but one of the interesting little cultural kinds of things that happened was this was a family from the South, and they had a very strong understanding that in the South, when you're sick, the family stays together. You don't go into the hospital and lay there by yourself with visiting hours where somebody pops in and sees you for a little bit and then leaves. The wife wanted to stay in the ICU with her husband. And at that point in time, I think things have changed at hospitals, but at that point in time, they did not want her in the room that much of the time. And so she had to fight her way into letting them keep her in the room. I guess if I had a message, I mean, it's hard on hospital staff. Remember, the hospital staff are trying to do a job, and they've learned the most efficient way of doing it. They've been doing it, most of them, for quite a long time. And so they've got to be getting their job done too. But you're going to have to find a way, if you're in that situation, to be able to speak up for what's most important and choose your battles carefully and try to be gentle on the hospital staff. They're not the ones who cause the illness. So, okay, yeah.
So what was the point at which you think a different choice could have been made that would have made the difference?
We've talked a lot about that. The two children are now in their 20s, and we've talked about where it could have gone better. I think that they are in pretty much agreement that they went wrong when we went to the emergency room. That he had wanted to die at home, and one of the issues for the wife was that when the ventilator point came was, I just want to take him home. And the hospital wasn't real willing to let that happen, nor was I comfortable knowing that I was going to be the physician taking care of him in those last moments. I wasn't that confident in my own ability to deal with that. So that's where our argument took place between myself and the wife. She decided that it would be better she was concerned that her kids had not been caught up to him being that sick. In fact, it came kind of as a shock when they threw him into the ICU. So with the septic infection. So
is that where something like 5 wishes would be helpful besides the power of attorney? I mean, were they really talked ahead of time about a lot of those situations? Because it seems just the power of attorney wasn't quite enough.
Yeah, and I don't know if the 5 wishes would do it or not. I mean, things as simple, it sounds simple. It's a simple piece. The wedding ring piece is a simple kind of thing that I don't think is going to get covered. No. Those minute little details.
But I think a couple of things you mentioned. I mean, he was 47 years old.
Right.
Otherwise thought to be healthy. They didn't know about the other diagnosis, so it was kind of unexplained, the criticalness of his illness.
Right.
And so I could see the medical team would probably, what's going on, we need a little more time.
When a patient comes into the hospital, they're assumed full code, which is full aggressive measures. It's only if we have documentation or expressions of wishes that they would not want to be a full code, do we lower that code status to comfort measures, palliative medicine. So in that situation, unless the hospital is told otherwise, you will be vented, you will get a feeding tube, you'll go through all the standard procedures. Now in the case that you're describing, if he had advanced directive, or if there was known that he would not want to be on a ventilator, and we're doing the time trials and getting to that point, typically an ethics consult would be called beforehand saying, we're going to have to vent this patient and it's coming up soon. What do we do? Do we do that or do we not let that happen? So
Do you have to have paperwork that shows, or can the spouse say
if
you would not want
we would do an ethics consult, so we bring the family and the team together and we would get these questions out. And if the spouse is saying he would not want this, then in my opinion, as the ethicist, I would say we should not do this. It would not be right to put him on the ventilator.
I'd be interested to know exactly how that works. The patient, it's 3 o'clock in the morning, and it's determined that the patient needs to go on a ventilator. Do they then call a meeting of the ethics committee? How does that work?
Yes, I am available 24/7. So they can put in, it's in the electronic record, there's an order. So the same way you can order chaplain services, social work, labs, you can order ethics to look at this case. It sends an email, it sends text messages, we have pagers, it comes to us and it says, if it's after hours, please call this number, and we have a list of on-call ethicists who will answer it, and we'll reach out and we'll have a conversation with the physician saying, how pressing is this? Is this something that needs to be handled right now at 3 o'clock in the morning, or is this something that can be handled tomorrow morning? And if they, depending on how extreme it is, depends on if we come in or not.
And if it is 3 o'clock in the morning, I'm sure every case is different, but generally, how long does it take you to make the committee, the ethics committee, to make the decision?
I'd say it takes about probably 7 hours worth of work before a decision can be fully established.
Somebody could die in that time, right?
Yes. So we try to make it as fast as, we work as quickly as possible, but we want to talk to the social workers, we want to talk to the nursing staff, we want to talk to the family members, we want to talk to family members separated. What if the patient is in the room saying that they, when the family's present, that they don't want to give up because everyone's saying you should keep going, but then whenever the family leaves the room and the patient's isolated, they say, you know what, I really don't want to keep doing this. So we want to talk to patients by themselves. We want to talk to family members separately. We want to talk to the attending. We want to talk to specialists. We want to talk to other members of the ethics committee who can have a different opinion, because maybe we all have our biases. Maybe I'm perceiving this from one direction and somebody else could be seeing it from a completely other perspective that I would not even know.
That is so helpful. Also, what role then does that written advance directive have? Does that trump everything else?
Mostly, yes. I mean, it's hard to say. I don't like saying absolutes, that it always does. There are extreme situations, but if a patient has an advance directive saying this is my wishes and an ethics consult comes in, that is what we go off of. We say this is the way the patient is talking to us, this is what we should listen to.
Do all hospitals have an ethics committee like this?
No.
No. How do you know which ones do?
Well, I was hired by Multicare about a little over a year ago. So before that, they had volunteers and it was not as functional as it is now.
Yeah, I'd like to have a clear explanation between a POLST document and advanced directive.
A POLST it stands for Physician Orders for Life-Sustaining Treatment. It is literally physician orders. So it is designed that you get discharged from the hospital, you sign a POLST and fill it out, and you have that available, and it's essentially the physician saying do not do or do CPR, chest compressions, artificial nutrition, and hydration. Now, since it's physician orders, it's not universally applicable. Say you have a patient or a physician who has attending rights at Multicare Hospital. You go in, you see that physician, they get you to complete a POLST form. You get discharged. Then you get readmitted to, we'll say, CHI Franciscan, another hospital. That POLST form, unless that physician has attending rights at that next hospital, those are not, his physician orders don't carry across. So those would be immediately voided because he doesn't have the right, or he or she does not have the right to make orders for the patient at that hospital. Now, advanced directive is universal. Even if you, no matter what hospital you go to, if you're from out of state, if you have these in an electronic record and are accessible, then those will apply in any situation. 5 wishes is a advanced directive. 5 wishes is a form of advanced directive. There's a ton of different advanced directives. 5 wishes is just one specific one.
2 years ago, I had surgery. I filled out one of those, which I thought was really a great form.
It is a good form.
Yeah, and I just want to say that what I did was I defined quality of life. I gave an ethical statement so my family could understand my thinking. This is all part of the form. And I said that if I were in a situation where they thought that I could return to the quality of life that I defined, then I could be intubated for, I don't even know how many days I said, but it was not for very long, because I've had experience with people being intubated in the hospitals and it's not been good. So does that cover it? For those of us who want to fill out those forms and define quality of life and define a period for which we would be intubated, if it would be the staff at the hospital believes we would be able to return to our quality of life.
If every patient did that, my job would be 1,000,000 times easier.
Okay,
That is wonderful. Defining quality of life, saying I'm okay with intubation for this long, only if you expect me to return to this state, this quality of life. If I am not expected to return to that quality of life, I do not want to be intubated. That is wonderful. That is everything that I'm trying to figure out whenever I'm doing consults with teams is what is the expected prognosis? What is the recovery? Is intubation just a time period, or is that because we have nothing else to do? Are we just buying more time, or are we buying a possible more quality?
well, thank you. That is really helpful because we need to know how we can have the most control.
Yes.
And I have to recommend that form.
Tell us again what it is.
And I actually have seen the 5 choices form, and I prefer the form that I work
tomorrow
with.
about that?
Kay Longy is going to speak tomorrow, and it's that organization. I think it's called End of Life. And if you Google End of Life, it'll come up, and they have a form that can also be used for dementia. It's really, really, really well developed.
End of Life Washington?
If you Google End of Life Washington, it will come up. I'm familiar with this group.
So that level of specificity is what we need.
Okay.
Okay.
Way in the back.
I just wanted to get a clarification about the pulse, because we got off of it fast. My understanding is people have done a pulse form with their doctor, and they have it like on their refrigerator. The intent of that is not to even go with 911 or go to the hospital.
Yes.
It's not. So it would eliminate that next step. If you have a pulse form at a certain, you tell people that 911 won't take you to the hospital, you stay at home.
So if you call the paramedics are coming assuming they're going to save life, and they're going to treat you as much as they can to get you to the hospital before a determination can be made. But if they see a pulse form on the refrigerator saying no CPR, that gives the paramedics permission to not essentially do their job. Because they can't just come in and say, I'm not doing CPR on this patient. They have to have the pulse form, and that's why the fridge is the most recommended spot, because it's visible and the paramedics know where to look for. They come in, they look at the fridge. If they see a pulse that says don't do CPR, then they can say we are not doing this, and they can refrain from doing that.
Can you just say more, though, about a pulse for most of us who are normally healthy, and whether or not we all have a pulse form in our refrigerator?
I do not recommend pulsed unless you, so Honoring Choices is a program through Washington. They define patients in 3 different categories. There are healthy patients, recent diagnosis patients, and then declining patients. So we have first steps, next steps, and last steps. Healthy patients are patients who, if you were to be told that they would pass away in the next 2 years, you would be surprised. So we could all have accidents, we could be living with chronic diseases, but if we are not expecting imminent death, then we're essentially a healthy patient. Then there's within 2 years you do expect it, and then there's last 6 months hospice care where death is we're preparing for. I would say pulsed is best for patients in last steps, end of life, essentially 6 months, 2 weeks, somewhere in there for pulse form. Everyone should have an advance directive. Everyone should not just have an advance directive, but have advanced care planning conversations, talk with your loved ones. Nothing is worse than whenever you come to the hospital and we ask the spouse, what would they want? Would they want to be intubated? And they say, I don't know. We've never talked about this. I have no idea. And then we do intubate and they say, this doesn't look right. I don't think that they would actually want this. Why did we do this? It creates a lot of moral distress for everybody. So events like this is one of the most wonderful ways of doing it, is think about death, think about the conversation, and tell people what you would want for your end-of-life care.
And give people a language and then give them permission to use the language. And that's what I think we haven't done in this society. My mom, at age 94, didn't wake up one morning at the adult family home where she was. I was just going to say this because it's an example of how fabulous they are. I was at Tai Chi. I had the power of attorney for health care. I couldn't be contacted. I met the ambulance on the ferry. I got in the ambulance and I said, can you tell me, I knew by looking at my mom that she wasn't coming back, but I said, can you tell me what the situation is? And they told me everything. And I said, can we turn the ambulance around? And they said, yes. This is a very, you're very brave. And I said, I'm not brave. This is what my mom would want, you know. And they turned the ambulance around and we came back and she died in her bed later that day. So, you know, the paperwork is critical. And I think that, but they are very, very kind and supportive. That is my experience.
Yeah, Ryan, you mentioned a couple times time trials. Can you explain that?
It's kind of like a see if this works. So if like someone was mentioning the ventilator and put them on for a little bit, let's see if they recover. Because sometimes the ventilator is a good thing sometimes, where it's not just prolonging for the inevitable. Sometimes it can be their body is very weak and they just need the machine to breathe for them for a little bit until things can recover, and then we'll see where we go from there. A lot of people who get into really severe car accidents go into the ventilator for a couple days and then they come off it. But without knowing if they're going to improve, and sometimes we can tell if they're going to improve. So having a conversation of, let's try a week, let's try 2 weeks on the ventilator. And if things are not improving, and if we feel that we're never actually going to be able to get off the ventilator, then let's discontinue life support and discontinue the ventilator. But you can try the ventilator for a little bit.
So is that where it would be really helpful to have a quality of life statement in the paperwork that says, if when I get off the ventilator I can't get back up to this level of quality of life, then that helps determine.
If it helps determine, is it even worth going forward, and at what point do we start having the conversation?
So, Mark, maybe you could speak to like the physician role. You mentioned like that patient, so they're on 100% O2, they can't wean them. What's the physician's role with the family to communicate that?
Well, the experience, several experiences, and it depends on the physicians a great deal. That there's some physicians. You see, here's we're coming out of, I like to look at the historical and the contextual kind of thing. We're coming out of a period where once upon a time the decision was pretty clear. You either lived or you died. Either you were breathing and your heart was beating, or it wasn't. And it wasn't that big of a deal, exactly, because it was either, life or death. And that binary decision was based on a whole system of medicine that worked on basically a Newtonian physics kind of aspect that, there's gravity and there's up and there's down. And the human body is a bag of chemicals that we can go in and we can fiddle with. We can throw some things in here and change health. Or we can lift the hood and fiddle with the liver and close it up and everything's good. See, medicine was really simple. And then the patients got involved. And that's where we're at now. And so there's some, you've heard, the doctor knows best. I have patients who come in who's they want to be more natural, but you can tell by the way they talk they don't really want to give up their lifestyle that they've had, that their medications are supporting them on. And so there's this crossover with physicians as well. There's those physicians who want to say, I know best, and I'm real sure of this, and I've got all my degrees, and I'm really an arrogant so-and-so that I don't want to even have you in my care, really, because you're just not good quality stuff. And then there are very compassionate, wonderful doctors who would turn the world upside down for you. So it really varies between, what sort of physicians. And in the case I was telling about, there was what was fascinating is that you couldn't really tell. You can't always tell. the gastrointestinal doctor who did was working with the rectal tumor had horrible bedside manner. He was gruff, he didn't answer questions, he was an excellent technician, but he was terrible with bedside manner. But at the end, he turned out to be the more compassionate, the more understanding, the more there with us at the end. So, you know, it's not always that clear, but, you know, the physician, you need to have a physician that you can work with. I guess would be my best answer, is that get to know the physicians that you're seeing and decide whether they've got the personality that's going to jive with yours. And if you're going to somebody just for their technical ability and their skill, then I wouldn't expect a whole lot of relationship with them, because they're in there to do one specific job that you want done. And again, it goes back to that, you're hiring them for a specific task to do something for your health.
Do you all have some final comments based on this comment?
I could. My recommendations are have conversations. Don't be afraid to have conversations. The statistics say that 70% of all people want to die at home, 70% of people do not die at home. So have these conversations. If you want to die at home, let people know that. Have that written down. Complete advance directives. Just let people know what your quality of life is. We use that word a lot, but the problem is it's very subjective. What we think is quality of life is not necessarily quality of life of the patient, which might not be what their spouse thinks is quality of life. And to some extent, the role of ethics in multi-care is to give the patient the care that we believe they desire and what would be able to fulfill quality of life for them. If we cannot meet their quality of life, we will change care to do so, but then we also keep ourselves unbiased so that we understand that we do not infer quality of life onto patients. We do not determine what it is. If they're not reaching what we think is quality of life, then we discontinue life support or anything like that. No, we try to figure out what is quality of life, and we try to make sure that patient can get a life that they feel is worth living.
I suppose I would say, last I saw a few years ago, 3/4 of our healthcare dollars are spent on the last 60 days of life. Mm-hmm. And a lot of that is the extensive last minute things that happen in hospitals. So, that's sort of a voice for dying at home if that is reasonable and possible. I don't know, I guess my last word would be willing to take on any sort of medical opinions that you don't necessarily agree with, and have that conversation. Don't be afraid to have that conversation with any medical professionals that you run into. None of us are God, and sometimes there's a few people in the profession that forget that. And sometimes you have to push kind of hard on those folks, but don't be shy about having the conversations with getting your needs met and your family's needs met.